There are so many things. We need to be engaging in a comprehensive review of our healthcare system in America. Fundamentally, what we're talking about is a basic resource economics problem. There is a high demand for a particular good or service. The only way you can deal with prices is by increasing the supply of that good. I'm not just talking about the pharmaceutical side of it, but I'm talking about the numbers of doctors and nurses and physicians assistants we have out there.
More Americans across the country are struggling to find physicians. In fact, one estimate projects a shortage of up to 48,000 primary care doctors in the U.S. by 2034.
We recognize that there are a limited number of doctors, and those doctors have a limited amount of time. The doctors are getting burned out. So we have this ever-widening gap between the number of patients that we have and the number of doctors that we need to be able to serve them. We need to be focusing on our healthcare system as a resource economics problem, which is something that we haven't done ever, as clear as I can tell.
Andrew, good to see you. How you doing today, brother?
I'm doing good. I'm glad to be back.
One of the issues that is just haunting the American public is the cost of drug prices. And It's probably one of those kitchen table issues that the American people have been suffering for a long time. And so when we look at the cost of drug prices, a big portion of that is because of just plain and simple, we're subsidizing the rest of the world to use medicines that were developed in this country. So 70% of all drugs are developed in the United States. And then these other countries, the other wealthy nations, they cap drug prices, such that what that means is all the innovation costs are borne and bared by the American people. Is this what you're seeing is driving a big portion of the high drug prices?
Well, I mean, listen, there are a lot of things that go into it, and some of it also is the regulatory regimes that we have in the United States, and the level of safety protocols that we put on drugs to make sure that they are safe and effective, requires a lot of testing. And that also lends to all of this. Here's the reality. There are a lot of things that go into the vibrant innovation that we have in the United States. And up until about 1980, we were losing a lot of the innovation race. And what we did was we instituted a series of laws that essentially supercharged our innovation economy. One of the great problems that then ensued was this idea of what happens when these drugs get exported. And one of the problems that we see is this idea of, well, how do we get at this issue where these other countries are not freeloading off of the United States, while at the same time we make sure that these nations don't, out and out steal the patents that are out there and thus kill innovation here at home. One of the things we have to remember is price controls are bad. Price controls are bad whether or not they're foreign, and price controls are bad whether or not they're in the United States. And so we have to be consistent in that regard while working as much as we can to put pressure on these other nations to pay their fair share. So one of the concerns that we have is the implementation of something called most favored nation, which is this idea of pegging prescription drug prices here in the United States to what our competitors who have this most favored nation status have, what they are paying for these drugs abroad, because what that will do is essentially institute price controls here and stifle innovation, and we don't want that to happen. There are a lot of ways to skin this cat, and one of them is to remember that the best way to bring prescription drug prices down is to allow the name brand pharmaceuticals to go through their period of exclusivity to recoup their investments in these drugs. And then that way you get the next generation of generic drugs that, while not being as effective as whatever is most on the cutting edge and still protected by the patent, cost nevertheless substantially less. So it's all of those things go into it.
There's two questions that spawn from that. The first being, what can we do to alleviate this price burden that other countries are putting on us by forcing us to subsidize their use? And the second is, how long is that exclusivity period justified before it becomes before itself becomes an issue. But I'll let you address those one at a time.
No, so this is obviously an issue. You know, whether or not it's not just the period of exclusivity, but whether or not that period of exclusivity, those rules get abused. I know I've got colleagues, with other organizations who are working on that issue to make sure that when name brand drugs make that transition from name brand to generic, that folks aren't abusing the process. Right? Because we know that 80% of the reduction in prescription drug prices come from that transition period. And should we have an examination over, how long the period of exclusivity ought to be? Maybe. But again, that just sort of changes the length of time that is at work here. The other part of this is the issue of putting pressure on these other nations, and doing so in the same way that the Trump administration has put pressure on the other NATO members to pay their fair share. There are lots of ways to skin this cat. What we just have to guard against here at home is the impulse to try to import or create price controls. Right? It was bad when the Biden administration worked to do this in terms of forced what they called negotiations, which really weren't negotiations at all, right? The threat of taxing drug companies at 95% if they didn't adhere to the price control demands of the Biden administration. The threats to upend the patent system that Kamala Harris talked about doing, that was a bad thing. And by the same token, this issue of both most favored nation as well as this, you still have folks who are calling for the allowance for prescription drug reimportation, reimporting the price controls of other nations. All of these things are essentially, they have the same effect, which is to stifle innovation. And innovation is the thing that ultimately drives down the prices of drugs.
It's essentially an unfair trade practice to have price controls in other countries that we are in turn subsidizing. What's the policy that you put in place to address it?
Well, I mean, this gets into the issue of negotiation and playing tough in negotiations with these other nations. It is a very difficult and dangerous dance at the end of the day, because what you don't want is to force the issue to the point where these other nations are essentially going to steal the patents and produce the drugs on their own. Because that again, violation of intellectual property rights, whether it's software or hardware or goods, all of these things are bad in terms of innovation. But it does take that negotiation, and it does take figuring out the best way to get the best America First deal out there. And I have great confidence that this administration can do it, far short of engaging in this kind of price control importation.
What is there in the negotiation in the toolbox that you can use if you're caught between trying to relieve the cost burden and then not trying to encourage them to do anything more deceptive? But what tools are in the wheelhouse that need to be utilized to kind of find that middle path?
Well, I think in the same way that we've been using the tariff issue as a cudgel to get nations to do this, I think engaging in the tariff negotiation on that side as a way of pushing this issue and saying, if you're not going to play fair, we're going to increase the price of other goods that you want to import here if you want access to these goods that are out there. But at the same time, we have to take a long, hard look here at home in terms of our regulatory practices, in terms of the cost that we artificially inflate to bring these pharmaceuticals on. Issues like right to try and allowing folks to engage in greater experimentation here at home, that helps hasten the development and the delivery of pharmaceuticals and medical services, devices into the marketplace, such that burden, the cost burden down the road, isn't quite so high. So all of these things work together. So
but isn't
things
that just
we can do here at home in terms of regulation and regulatory practices, while at the same time, dealing with the various tools that we have in terms of trade generally to get what we want.
But here at home, a lot of these regulations are just a bureaucracy trying to further justify itself. It comes down to much of that. So you have the entire pharmaceutical regulatory agencies, just whatever you want to call that. It's almost an industrial trade complex that is putting these burdens on them, which further justifies more employees. And it's just like trying to get the speed rail in California, where you just do study after study and nothing comes to market. It's something similar to that, correct?
Well, I literally just had a conversation with Adrian Moore, who's the VP for policy at the Reason Foundation, and talking about trying to find this happy medium between, the deliberative regulatory reform process and just sort of rocketing along willy-nilly, right? There's got to be a happy medium there. At the end of the day, right, there are so many things. We need to be engaging in a comprehensive review of our healthcare system in America and recognizing that there's a fundamental difference between health insurance and health care. Fundamentally, what we're talking about is a basic resource economics problem, right? In all of these circumstances in which there is, a high demand for a particular good or service, a very limited, and in fact, when we're talking about medical care, a declining supply, the only way you can deal with prices in the face of an increasing demand is by increasing the supply of that good. That's how we go about doing this. So it's right. Pharmaceuticals, prescription drugs, as well as devices, they're only one part of the equation in all of this. We need to be focusing on our healthcare system as a resource economics problem, which is something that we haven't done ever, as clear as I can tell.
How are you going to increase that supply and still maintain that incentive for the drug companies to get the returns for their shareholders?
Well, right. I mean, this is part of the reason why you had the period of exclusivity. And the reality is, of course, that so many of the name brand pharmaceutical companies are producing their own generic drugs at a very, very small margin. That's an important issue. But let's keep in mind again that what we're not just talking about when I talk about the resource economics side of it. I'm not just talking about the pharmaceutical side of it, but I'm talking about the numbers of doctors and nurses and physicians assistants we have out there, which is such a huge role in all of this. And the fact that we are not only have a limited number of medical school births, but we have a very limited number of residency programs. We haven't changed the formula for how those residency programs get funded. So all of these things, we need to be looking at the issue of supply. That's how we reduce not just the price to consumers of prescription drugs, but also the issue of healthcare generally. Oh, and let's add into this, I'm sorry about this, but when you talk about the relationships here, the hierarchical control between the big insurance companies and their pharmacy benefit management firms, which have not produced, the drug savings that we were all promised. In fact, that's why the FTC under both Republican and Democrats have been looking at PBMs and their role in keeping prescription drug prices high for consumers. All of these things need to be looked at.
Well, there shouldn't be related parties to be allowed to conduct business in that situation. You can't have the insurance and the pharmacy management companies under the same roof.
Right.
It's just plain and simple.
And both serving, by the way, to push out the independent pharmacists out there and the pharmacists who have great relationships with their customers. The issues of compounding and how that goes into it. I mean, all of these things conspire, but we have not looked at this in a really comprehensive manner. And part of the problem, is that everybody seems to think that they have, they have their perspective on it. They don't want to open it up to anybody else. So you have folks who see our healthcare issue in America as an insurance issue, and you have other folks who believe it's all about the marketplace, and farmers, PBMs are an integral part of the market. So all of these things we have to be looking at.
Well, you got to get more doctors out there, and one of the things that the physician industry is doing is they're trying to protect their wages, and they don't want to flood the market with new doctors and new residents that will result in a supply demand relationship that hurts their pocketbook. But what a lot of countries do is they have different levels of doctors. We do have where you have your physician's assistants and your nurse practitioners. But in a lot of the Latin world, what they do is they have, if you got a cold, you have access to a certain doctor that you can go into for less than 100 pesos. And then but if you have a real issue, you have to go find an MD somewhere. And we don't seem to have that same cheap access to medical providers for these lower instances of poor health.
Well, let me add to this. And again, like any kind of a market-based system, when you have an increased demand for a good and declining supply, right? One of the most devastating things that we did, and I was warning about this when we were talking about the Affordable Care Act, 15 years ago, is when you increase demand, by 15% or 20%, right? You add 20% more patients who now get this chit saying that they have access to health care. But we recognize that there are a limited number of doctors, and those doctors have a limited amount of time. All of a sudden, you have physicians who are having to see more patients in less time. You're not changing anything on the liability side of things. The doctors are getting burned out. You have an increasing number of independent practices being taken over by hospitals and big healthcare systems, and they want to push down reimbursement rates. And so that accelerates the decline of the supply curve. And so, that's the nasty part of it. So we have this ever widening gap between the number of patients that we have and the number of doctors that we need to be able to serve them. And add into this the fact that we have a number of residency programs that essentially hasn't changed in 30 years, or the formula for funding those residency programs hasn't changed in 30 years. So there's no incentive to do that, right? So we could, for instance, open up, let's say, 50 more medical schools in America today, right? And increase the number of doctors in America that are trained in America that way. But if we don't increase the number of residency programs that are out there, especially in basic primary diagnostic care, then what good is it, right? Because then you don't have the doctors who are trained. Again, we have not looked at this in a comprehensive fashion in a very long time, if ever, and we really very much need to.
Yeah, and the other way to do that is you got to, when you do business or when you're creating policy, you got to play the piano with all 10 fingers. And so there's not enough reciprocal resident programs for other healthy Western nations. There should be residents. You should be able to get a residency in France that translates to getting board certified in.
I don't know, man. I don't know if I want a French doctor treating me. No, I'm only joking. I agree wholeheartedly. I mean, I think in America, if you have the aptitude to go to medical school, you have the test scores, you have the grades, you should be able to find some place to go to medical school, and that's a real problem here. Again, it's that. So all of these things. The point is, all of these things. We could talk about certificates of need, the idea that if you have a new service or device delivery in a community, in so many states, you have to get the buy-in from everybody around you who don't want to see their particular portion of the apple cart or the healthcare marketplace upended. They get to approve on this. So many states are dealing with that. So it's so many things that go into this. And yes, prescription drugs are a huge part of it. But what we don't want to do is stifle innovation. And we need to find ways to address those things.
But a lot of these, what you call it, so these trade unions or like
trade associations,
that protect themselves. It's just another form of bureaucracy. It's a horse of a different color, but still a horse nonetheless. And so you have the bureaucratic institutions inside government and those in the trade associations. They're really just getting in the way of a lot, right? So we have inhibited markets. And I understand Andrew, you can't. I understand you're a diplomatic guy, but it's and that you're trying to get things done. And I'm not asking you to burn relationships, but what do we got to do to relieve some of this bureaucratic burden? That's what we're all getting choked by.
This is a lot of what this administration is doing. that's the good thing. I mean, I think, at the end of the day, looking at some of the good people who've been appointed to senior policy positions at HHS and elsewhere, they're really getting at the root of how to supercharge these efforts so that we can bring things to marketplace faster. That's so vitally important at the same time, right? So you've the senior officials, you've got the DOGE effort out there to look at the bureaucracy and the structures they're in. At the same time, we're engaging in unprecedented levels of soliciting for information from everyday people, their recommendations as to how to get these things done. Those are going to be implemented. That's all part and parcel of this process. I think, when you and I talked the other day, we've had my good buddy Wayne Cruz of the Competitive Enterprise Institute just had a piece in Forbes the week before last. The single most consequential 6 months of any administration in the modern era in terms of deregulatory actions. I'm filing right now on average about 2 different sets of comments per week with agencies, not just on healthcare, but on other issues, making recommendations as to how they can make things better. In fact, as we were getting ready to do this today, a set of comments to the Army Corps of Engineers, who are finally addressing what the Supreme Court told them about what are called nationwide environmental permits and the nationwide permitting process, making recommendations in that regard. So these things are getting done. It's just a matter of watching it. And when they're not being addressed properly, making sure that the folks who are making these decisions are aware of the deficiencies therein.
Right on. Well, hey, thanks for joining us today, Andrew.
Always.
And we'll stay in touch, man. I always enjoyed speaking to you.